Well, hello, everybody. My name is Robert Cahoon. I'm the Director of International Campaigns for 40 Days for Life, and welcome to this online briefing session about responding to the consultation on DIY abortions. We are a coalition of pro-life organisations who have put this event together, and thank you for joining us. Your response to this consultation is very, very important, and it has been wonderful seeing so many pro-life organisations come together. I work for 40 Days for Life. We help Christians end abortion where they live. We organise prayer vigils outside of abortion centres. And what's great about this event is we've come together with many different organisations to help you respond to the consultation from the Department of Health and Social Care to whether dangerous DIY abortions should be made permanent. You might have seen the film Unplanned, which actually shows a DIY at-home abortion taking place. If you haven't seen that film, you can go to Amazon Prime and rent that film online in the United Kingdom. It shows the graphic reality of a DIY home abortion, what this is really all about. And legislation was passed in the United Kingdom last year, allowing DIY abortions for the first time. And this is a chance to make your voice heard, to respond to the government's proposals here. And this is something really tangible that you can do. And maybe this might be the first action that you've ever done for the pro-life movement in the UK. Maybe it's an opening door for you to get involved in the pro-life movement more and more. There's so many different groups as part of this online training session. And we're going to give you practical step-by-step instructions about how to fill in this consultation form. So we're with Alethea Williams from the Society to Protect Unborn Children, and Kevin Duffy, a former consultant to Mary Stopes International, a major abortion provider. And they're going to walk through each consultation question with suggestions for points that you can include in your responses. And the reason this is important is that we need to be a voice for the voiceless. We need to speak up for those who cannot speak for themselves. And we need a paradigm shift in the pro-life movement in the United Kingdom. And this is the first stage of that happening, helping to respond to what's happening in the political sphere in a professional, collaborative, dynamic, strategic response to what's happening in this country with regards to abortion. And I'd just like to invite you to consider what more you might be able to do for the pro-life movement in the UK. We've got this consultation here, but there's so many other groups involved. There's practical, pastoral, political, prophetic ways of getting involved in the pro-life movement. And I just warmly invite you to get involved, to do what you can on the local level. Maybe there's one person in a crisis pregnancy in your community right now that you might be able to reach out to, you might be able to help. And this consultation will plant the seeds of thought, the seeds of ideas, of practical, tangible ways in which you can respond to the crisis of abortion in the United Kingdom. It happens one person at a time. And with our movement, 40 Days for Life, we're about on the local level. We're reaching out to those in need in the local community, saving lives one person at a time. So thank you so much for joining us. I hope that you find this event informative, inspiring, equip, empower you to end abortion where you live. And this consultation is a very, very first stage. So I'm going to pass over to Alethea Williams from the Society to Protect Unborn Children. Alethea, how are you today?
I'm very well, thank you. Thanks for your introduction. Thanks for joining us.
Brilliant. Well, do take it away in the step-by-step instructions about how to fill in this consultation form.
Great, thanks so much. So I just want to kind of position how we're going to talk about this today. Obviously, many of you will be our supporters from pro-life groups, and many of you may be new. And so just to position it, obviously many of us are completely against abortion, and we're fighting to end abortion in any way. So why are we particularly talking about these DIY abortions? And of course, it is the case that abortions carried out in a clinic are equally as morally wrong as those carried out at home. But for the purpose of this consultation, we're asking pro-life people to put the case to government of the dangers to women from home abortions. And it is really important. Home abortions that we're seeing now are part of the abortion lobby's agenda to make abortion completely normalised. They also want decriminalisation, they want it over the counter, they want it as easy as possible. So we have this really important opportunity to respond to this, to oppose this. And so we need to make our voice heard, as Robert said. And we do need a massive response to this with these consultations. It is a numbers game. So what we want to do today is make it as easy as possible for you to fill in this consultation. I think we're going to get up on the screen what the consultation looks like. Here we go. So it's quite a simple system. You just go to the government website. I think we'll be putting the link in the comments. So there are 10 questions, and they have tick box responses, and then there are some boxes for free text comments. And what we're going to do today is we're going to walk you through each of the questions, and we're going to suggest which of the answers you tick, and then give some pointers for what you can put in the free text. Don't feel you have to put absolutely everything that we're going to say. And Kevin and I will be coming at it from slightly different perspectives as well. So some arguments might appeal to you more than others. So just as we're going through, either fill it in now as we go along, or take notes, put everything in your own words. And hopefully this will give you some good ideas. So to crack right on with the first question, the first question that is on the consultation is, do you consider the temporary measure has had an impact on the provision of abortion services for women and girls accessing these services with particular regard to safety? So what we suggest that you put for this one is that yes, it's had a negative impact. So obviously this is a very important question. Safety is one of the key reasons that we're opposing this change, these DIY abortions. And safety will come up in some of the other answers. Some of these questions overlap a bit. But just to get us started here are some points that you could include. So firstly, carrying out a DIY abortion at home is a painful and traumatic experience for women who are often alone. There's also the worry of vulnerable women can be forced into taking abortion pills. So there's been a spike in domestic abuse during lockdown, and many women will have been forced into ordering pills by an abusive partner. When you're just ringing up to get abortion pills, there's no way of knowing if there's any coercion going on. These women could also be coerced into carrying out the abortion with only their abuser present, and then they would be unable to phone for medical help because the abuser would hear. So there was actually one case of this reported in the Daily Mail of a woman in an abusive relationship who called up, got the pills, and she had a particularly awful time with it physically. It was a really, really traumatic experience. And she says, the next day I felt really sick, faint and dizzy. I'm still bleeding even now, a few weeks on. Because my partner is here and doesn't know what I did, I've not been able to ring anyone for advice. And then the next point is that women may take the abortion pills past the 10-week limit. So there have been reports of women in England taking abortion pills past the 10-week limit, including some past the legal 24-week limit. So Kevin did a mystery client investigation, which actually brought out a lot of these safety concerns, including about the 10-week limit. So I'll just pass on to Kevin now.
Okay. Hi, Alethea. Thanks for that. And thanks, Robert, for your kind introduction. It's a pleasure to be with you here this morning. So thanks for asking, and thanks for having me. So yeah, I'm going to start just with a little bit of a background introduction to our we're referring to it as a mystery client investigation. Some may know these better as a mystery shopper investigation. And last year, Christian Concern commissioned the investigation, and we had a team of volunteers. What they were doing was making calls to the abortion providers. They were posing as pregnant women seeking abortion, and the volunteers were, in a sense, acting out a number of different roles, and we had designed the roles to fully explore aspects of safety and compliance with the regulations. I think there's a link up to the investigation report, which if you're interested, you'll be able to access that later. But for now, in 26 cases out of 26, our team was able to obtain the abortion pills by post, even though they provided false information and they weren't even pregnant. So the investigation demonstrated a few things. In particular, it demonstrated that the abortion providers, they cannot identify correctly. They cannot identify the woman. They can't correctly assess a woman's eligibility for medical abortion at home, her clinical eligibility. And they can't be sure how far on she is in her pregnancy, whether she's under the legal limit of 10 weeks, whether she is safe, whether she is alone. They don't know whether she's being coerced. And importantly, they don't even know if it's the woman that's making the call but will actually be taking the tablets afterwards. And I want to just give you 2 or 3 of the stories, the cases that we used to give you a bit of an inside view as to what went on. In one of our cases, the caller was posing as the mother of a pregnant teenage daughter. The mother made the calls to the abortion provider. She presented herself as the one being pregnant, and she obtained the abortion pills. And when the pills were received at home, she then administered those pills to her pregnant daughter without social services or the daughter's GP or any other safeguarding being involved. In another case, our volunteer was posing as a woman who was being coerced by her abusive partner. And when she was making the calls to the abortion provider, the abusive partner was sat beside her, making sure that she gave the right answers. And the abortion provider clearly on the phone wasn't able to discover that the coercion was taking place, that in fact, that even the person was sitting there. Telemedicine abortion normally involves 2, maybe 3 phone calls to the provider over a couple of days. And usually the woman will be asked on the first call, she will be asked to give the first day of her last period. And that's how they assess how far the pregnancy has gone. And the legal limit for that is 10 weeks, under 10 weeks since her last period. Okay. And in one of our calls, this woman, the volunteer, gave a date in the first call, and then in the second call, she changed the date to present as being earlier in her pregnancy. She realized that the date she had given would have put her over the 10-week limit, and so she changed the date on the second call to make herself appear just 7 weeks pregnant. And in 4 cases out of 4, the service providers just accepted that and moved on with the provision of the pills. And I think, as Alethea has already said, it's important for us to note that this isn't just from our mystery client investigation, these findings. Okay, you referred to an NHS email. There was an email leaked from the NHS in about May or so of last year. And in that email, it was sent by a senior chief midwife to the clinical directors and heads of nursing in a particular region of England. And in it, that she raises significant concerns, ongoing concerns about the pills by post process. And 13 incidents are noted in that NHS email, including, sadly, the delivery of a baby at 30 weeks gestation. There are 3 police investigations, and one of those is a murder investigation because of concerns that the baby may have been born alive. So terrible situations. And at the time that NHS email was being talked about in the press, round about the early summer of last year, BPAS responded saying that it was investigating internally a further 8 cases in which it had provided abortion pills beyond the 10-week limit. So that's NHS and BPAS. And then in October, the Department of Health and Social Care revealed that it had been notified by abortion providers that in the first 6 months of 2020, 52 women had received abortion pills at home beyond the 10-week limit. It's important to note that these are the known reported cases. These are officially reported cases. So it begs the question of how many more of these events have occurred without either the abortion provider or the regulators finding out or knowing about them. It's not just Christian Concern through their investigation that are raising these concerns, but senior managers in the NHS, the DHSC, the Department of Health and Social Care, Hancock's department, and BPAS, one of the abortion providers, have each revealed and agree that women can obtain pills by post when they're beyond the legal limit of 10 weeks. So that we need to consider, and that's one of the reasons, or a lot of the reasons, why we're saying yes, it has had a negative impact. Alethea.
Yes, I think it's very clear that even in the fairly short time period that we've had these DIY abortions, there is definite evidence of safety concerns. It's not just us assuming that things will go wrong, though we did. There is plenty of evidence that we can put in here. Okay, so to move on to question 2. Do you consider that the temporary measure has had an impact on the provision of abortion services for women and girls accessing these services, with particular regards to accessibility? So for this one, it's okay to answer, I don't know, if you don't know. But Kevin has some suggestions for answering it has had a negative impact from his public health perspective.
Thanks, Alethea. Yeah, I mean, this is something that I've been working on for a long number of years, maybe 10 or 15 years now, is looking at how to improve access to healthcare services, and telemedicine and the use of, for example, internet services, web services are clearly part of that. And in my view, I just don't consider wholly relying on telemedicine as being an appropriate way of providing abortion services. I think telemedicine does have a role, and it can be part of that care pathway, but this approval and what we call DIY abortion at home, or telemedicine abortion, whatever words we're using, we need to understand that this is for the whole process, end to end. And I just don't think that's appropriate for such a service. I think that some are saying that telemedicine is cheaper and it's quicker than in-person appointment. But we need to remember that the aim of medical care is not merely to adopt the cheapest or the quickest approach. We need to also and always consider the safety and well-being of those being served, and of course, compliance with regulations. And our investigation has demonstrated that the telemedicine system, the process that's being used, doesn't protect those aims of safety, nor does it protect compliance with the regulations. It doesn't ensure that. And it remains wide open to abuse or deception. Sometimes the woman may be misleading the service provider without intending to do so. Okay. Service providers are solely relying on whatever it is the woman discloses, whatever she answers to the questions given, whatever she recalls about her medical history. That's how they assess the eligibility. And I'm just suggesting that perhaps telemedicine is not the most appropriate for that. Okay. The issue of cost has come up a few times, Alethea, in the debate about telemedicine, and this debate in particular about telemedicine for abortion. And I think we need to remember that cost shouldn't be the overriding consideration for us in any of this. And I think for women who may find it difficult meeting the out-of-pocket costs involved in traveling to clinics, or maybe missing days of paid work, or needing to pay for childcare. These are all reasons given for telemedicine. My view would be it might be better for the NHS to remove that cost barrier by actually offering financial assistance to these women in order that they can make in-person clinic visits for their consultations. Okay.
Thank you. Move on to question 3. That question is, do you consider that the temporary measure has had an impact on the provision of abortion services for women and girls accessing these services, with particular regard to privacy and confidentiality of access? So this is an important question because privacy is one of the key reasons that the abortion lobby puts forward for having abortions at home. It's all about, you can be in the privacy of your own home, the comfort of your own home. And so some points to come back on that point. So as we've mentioned, we don't know who's going to be at home with the woman. We don't know if she's being coerced. We don't know if there's an abuser present. And actually, with for all the faults of abortion in a clinic, which obviously we're opposed to anyway, but one of the things that happens there is that a woman's always seen alone, even if she has a support person, the partner, father, with her the rest of the time. There's always a time when the woman is seen alone to make sure that she's not being coerced, that it is her own decision. And so, as we've mentioned, with a telemedicine consultation, it's impossible to ensure that the women are alone. We don't know that they do have any privacy or confidentiality. And there's also the danger with this being done by phones, particularly, that an abuser might be monitoring her phone. Something like 3 in 4 women who are victims of domestic abuse also report technological abuse in this way. And I think there's also points from the mystery client investigation that are relevant here in terms of the privacy and confidentiality.
Yeah, so clearly abortion providers are taking their safeguarding responsibilities seriously. And so when they talk to women on the phone, they will always ask, are you alone? Are you in a private place? They will ask a number of times to confirm if the woman feels safe and able to respond to the questions and able to actually go through the process of having the abortion at home by herself. And some of the questions, I mean, I've listened to 90 phone calls now with service providers through this process. And, some of the questions are quite involved. They get into a lot of specifics about potential domestic abuse or intimate partner violence or other similar coercion type situations. But from my perspective, it doesn't really matter how well worded those questions are, and it doesn't matter how good the intentions are behind them. Using telemedicine, the abortion provider simply isn't able to be sure, to be certain that the woman isn't being coerced. And on the investigation, we had a number of calls being made where the volunteer was sat on the sofa and sat beside her was her abusive partner, listening to the call, listening to the conversation, and poking her and prompting her to answer the correct to give the correct answers to specific questions. And during those calls, the abortion provider at the other end of the telephone just wasn't able to discover that there was somebody sitting beside that woman coercing her at that point in time, even though she answered, yes, I'm alone. Yes, I feel safe. I know I'm not being coerced. She answered all those questions, the right way, as it were, but the abortion provider just simply cannot tell. Okay.
Yeah, I mean, that's just really important. Okay, moving on to question 4, which is, do you consider that the temporary measure has had an impact on the provision of abortion services for those providing the services? So this might include greater workforce flexibility, efficiency of service delivery, value for money, etc. So obviously most of us answering this are not NHS workers or particularly involved in providing these services. So it's okay to say I don't know for this one. Which I should mention that you don't have to answer any of the questions as you go through. You can just choose the ones you want to answer, but hopefully we're giving you enough information that you can answer most of them. So for this one, it's all right to answer I don't know, but if you did want to answer it's had a negative impact, then again, Kevin has some suggestions from his perspective.
Yeah, that's good. And I think that, I'm sure that some people listening or watching this may well work for the NHS, may be a healthcare provider. You may have an interest in the provision of healthcare services, and therefore you might want to give a different answer. B is what I'm suggesting. I would answer it B. Yes, it has had a negative impact. And the reason I answer that is having worked with healthcare providers for a good number of years now, I just know that they're not fully satisfied with telemedicine assessments of patients. So if they solely have to rely on doing a clinical assessment by telephone only, then they know that they cannot be certain and they cannot properly assess the safety or the suitability of the medicine, the treatments that they might be prescribing. And they won't be able to, and they know they won't be able to correctly and properly assess the gestational age. So the gestational age is the most important aspect when it comes to safety and efficacy of the abortion pill treatment. And using telemedicine, telephone only, clinicians know that they cannot be certain about the gestational age, and they cannot be certain about the medical history and therefore the suitability of the abortion pills for their patient on the other end of the phone. So it's very unsatisfactory from a healthcare provider's perspective. And I know I've said it, but let's just pick it up again. I want to deal with the cost issue. This question mentions explicitly value for money. Okay? And I think we need to bear in mind that the overall cost of the abortions in the NHS budget is a very, very, very small part of the overall NHS budget. And so we should not be swayed by potential savings. And we haven't seen any savings come through yet. The fees being paid to abortion providers haven't been changed yet. But we shouldn't be swayed by potential savings in this. We shouldn't allow cost savings or value for money, as they put it, to weigh more heavily than ensuring that each woman is correctly and professionally assessed, and that she's presented with an opportunity to discuss any of her concerns in person with a trained counsellor before she gives her consent to the abortion procedure. Okay.
Yeah, I think that's a really good point. The abortion lobby talks so much about the importance of women's healthcare, of looking after women. So to have questions of value for money in this is a bit disturbing, really. Question 5 is along similar lines. Have other NHS services been affected by the temporary measure? And actually, at the time that I wrote the SPUC briefing on this, we just put, I don't know, because we didn't really know. But actually, and again, it's okay to answer that if you're not coming at it from a healthcare perspective. But actually, we do have some more evidence now that it is affecting other services, again, from the mystery client investigation, and some very interesting new evidence on freedom of information requests.
Yes, thanks, Alethea. So I would certainly answer yes for this question. And just as background for those watching, so when a woman makes these calls to the abortion providers, the providers tell the woman on all of the calls to watch out for the signs of complications, and they describe what these signs of complications might be. So we're talking about things like heavy bleeding that's heavier than normal, perhaps risky levels of bleeding, or if indeed that the abortion might not have worked correctly, that what they call an incomplete abortion. So an incomplete abortion is when the abortion pills don't work correctly and parts of the baby, parts of the placenta remain behind in the womb. And so the abortion providers talk this through with the women on the phone, and they tell them what to look out for. And the instructions they give are consistent on all of the calls I've listened to. The instruction is that if any of these things occur, if you see any of these red flags, any of these warning signs, then immediately go to your nearest accident and emergency department. Go straight to the hospital. Don't phone us, go straight to the hospital. And that's important because if particularly, let's say, on the bleeding, if the bleeding is heavy and heavier than it should be, then of course the woman is at risk of hemorrhaging. Okay. And if she doesn't deal with an incomplete abortion correctly, then if sadly parts of the baby, parts of the placenta are left behind, there's a risk of, well, ongoing bleeding and certainly a risk of infection, which may well lead to sepsis. And I want to state here, look, it's not the abortion providers that are managing these complications. So they've given the warning signs to the woman, and it's the woman herself that is now left to assess whether the abortion is completed correctly, whether she is bleeding the right amount of bleeding or more than she should be bleeding. And it's up to her herself to get herself to hospital. So the abortion provider is no longer involved. In truth, actually, what the abortion provider has essentially discharged their client at the point at which they send out the pills in the post. For all of our mystery clients, none of them received any follow-up calls proactively from the abortion provider. The abortion provider basically sends the pills out, and that's the end of it as far as they're concerned. Go to the hospital, go to the NHS. So we followed up on this. We wanted to get our own primary evidence on this, and we've made some freedom of information requests to NHS trusts, NHS hospitals, and to the ambulance services. And what we're finding is the responses coming back are providing us with data that supports this, that show that actually, yes, hospitals, ambulances and hospitals are dealing with women who are self-reporting now with incomplete abortions or heavy bleeding. And those numbers have not declined. Those numbers are as high, if not higher, than they were in years previously. So this whole at-home abortion is not safer. Okay? The safety issues, the complication issues have not changed. Okay? And that's what we're finding from these FOI requests. And we will be reporting those more fully over the next few weeks. But for now, just bear in mind that it's the woman herself that is left to look after her ongoing care, to decide whether she is doing okay, whether the abortion is working correctly, or whether she needs to go to hospital to get other help. Okay.
Yeah, so that's really important information, because some of you might have seen that abortion providers have been claiming recently that DIY abortion is actually safer because the complication rates showing up in the official statistics are lower. But as Kevin's pointed out, once they send out the pills, that's the kind of end of their involvement. So normally if there's a complication that happens in the clinic, then they have to write that on the form that goes to the government. But clearly they're filling in these forms as they send out the pills. They're not hearing about any complications. They're not going on the form, so they're not getting into the official statistics. So any complications are now showing up in these FOI requests to hospitals and ambulance services, not to the abortion providers. Yes, so to sum up for that question 5, it seems that other NHS services are being affected because they're now having to take on this responsibility for dealing with women who have complications arising from the medical abortions. Okay, so question 6. What information do you consider should be given to women around the risks of accessing pills under the temporary measure if their pregnancy may potentially be over 10 weeks gestation? So this is a free text question, there's nothing to tick. And it's actually a really interesting question because this seems to me to be admitting the fact that there is a risk of women taking these pills over 10 weeks. And I should probably mention what this 10 weeks thing is about. Many of you will be aware that the legal limits for abortions generally is 24 weeks in this country in most conditions. But this temporary provision for pills by the post only allows it up to 10 weeks gestation in England. It's slightly different in Scotland. And that's a kind of a medical-based limit. It's not suggested that pills be used past that point. So it's interesting that they're admitting that this is happening. And again, when we're answering this question, we're pointing out the particular risks of abortions over 10 weeks. It doesn't mean we're saying that abortions below 10 weeks are morally okay or anything. So one point we could begin by saying is that women should be given full information about the risks of abortion carried out at any gestation and under any circumstances, because there are risks. And women over 10 weeks should be offered counselling so that she has the opportunity to think about keeping her baby and avoid an abortion which she could regret for the rest of her life. But to list the particular risks of abortion pills over this 10-week limit, so these pills, and it's two, you take 2 drugs, one which cuts off the nutrients to the baby so the baby dies, and then another one that it expels the baby, causes a miscarriage, as they put it. So they're designed to be taken up to 10 weeks in pregnancy, as they are less effective and more harmful for the woman when taken later. So, for instance, in one UK study, more than 50% of women having medical abortions after 13 weeks needed subsequent surgical intervention. And just to say, obviously, you can go and find the briefing. There'll be a link to the briefing if you can't remember every stat I'm reading out here, but I think it's important to go through them. So the abortion complication rate also increases rapidly with each week of gestation, with one study finding a 38% increase for each week. Recent research shows that 16.3% of women who had medical abortions at 57 to 63 days and 20.5% of those who had medical abortions at 64 to 76 days made an unscheduled return visit because of the concerns about complications. And for 77 to 100 days, that figure rose to 22.5%. So the key point there is that the later in gestation when women are taking these pills, the more they're then having to make hospital visits anyway, which obviously removes any benefit of an at-home abortion. Another point that we could make is the issue of pain for the unborn baby. So some researchers believe that pain sensation may occur before the 10th week of gestation and possibly as early as 6 to 7 weeks due to maturation of particular neural structures as well as the lack of pain inhibition mechanisms. And another important point is by 10 weeks, the unborn baby is 1.5 inches long and clearly recognizable. So that may cause more distress for women passing the baby alone at home. I think we do have, obviously it's not nice to think about the reality of this, but I think there is this kind of view maybe in society that you take these pills and the baby goes away. It's like, you know, magic. That's not what happens. They do have to pass the baby, there's bleeding. And obviously the more advanced the gestation is, the bigger the baby is. So the more traumatic that process is, and the more likely that the woman is going to see something recognizable as a baby. And then she has to dispose of those pregnancy remains herself, either into the toilet or into sanitary pads. And actually there was, I remember reading in the mystery client investigation what the providers are saying to the women about this. And it's very clear that it's not a nice thing to be going through. So yes, do you have some more things to add on this one, Kevin?
I do actually, yes, thanks. So I'm not too sure, Priscilla, do we have the BPAS table? Thank you. Okay, so I think that women do need to be told a lot more about how things change with each week of gestation. And I just bring to your attention, this is on the BPAS website, a table that shows the difference between, these are the side effects and the adverse, the complications and the side effects up to 9 weeks, and then in the 9th week, so that last week of the 10-week legal limit. And about in the middle of that, you can see that there's one on the potential risk that reads, needing surgical treatment to complete the abortion. And up to 9 weeks, that's 3 women in 100. Okay, so 3 times out of 100, she will need surgical treatment in order to complete the abortion. That's the incomplete I talked about earlier. And look, the change in 1 week. And this is still within the legal limit. So in that 9th week, it goes to 7 in 100. And that's the trend. So as the gestation changes and gets, as the pregnancy develops and gets later, these side effects, the risks of side effects, the complication rates increase. Okay, and okay, that's fine, thanks. So I think that what this question demonstrates for me, and Alethea has already said it, is look, in asking the question, the government, the DHSC, is acknowledging that some women will be beyond the 10 weeks. And in fact, since our investigation, I've noted that some of the later calls, some of the calls that we're doing in the last couple of months, the abortion providers are now saying, are you sure, dear, that you've given us the right date for your last period? Are you sure that you're only 9 weeks? You wouldn't be any more than that. And, you know, so they do ask the question a bit more. And remember what we said earlier, that even the official data show 52 women were provided by the abortion providers the pills beyond the 10-week limit. So we know the guidelines issued by the Royal Colleges also say this. They say, look, we trust women to get their last period, the date of their last period correct, but we should bear in mind that sometimes this won't be the case. So we should be expecting some women to be beyond the 10-week limit. So beyond the 10-week limit is illegal. If the abortion provider knows about it, like in those 52 cases, those are 52 illegal cases, okay? And as Alethea is saying, and indeed as BPAS is pointing out, the risk of trauma, the risk of side effects the risk of complications increases, and sometimes quite significantly, as the pregnancy develops. So.
Yes, so definitely plenty to
Sorry,
say.
I just left it hanging there. I think for me, it's just a very cynical question. It's like, we know women are going to be over 10 weeks. What should we do about it? You know, it's a cynical, and where's the care for women in this? You know, really.
Definitely. Okay, so we come to question 7, which is, outside of the pandemic, do you consider that there are benefits or disadvantages in relation to safeguarding and women's safety in requiring them to make at least one visit to a service to be assessed by a clinician? So this is basically the crux of the whole issue. You know, should we be sending pills in the post, or should we be keeping the status quo of women going into clinics? And again, this can be a slightly difficult one for pro-life people to answer, because obviously we don't believe abortion should be happening at all. But for the purposes of this consultation, we're talking about the risks of pills by the post, of DIY abortion. So obviously the answer to this is yes, benefits, but what we mean by that is there are risks to what's happening now. So, I mean, most of the risks we've kind of talked about in the other questions, but we'll just go through them, and there's a few new ones. So one would be not adhering to the precise time intervals between the 2 stages of the abortion. So as I've mentioned, there are 2 pills that women take, the mifepristone, the first pill, and the misoprostol. And it is important how those are taken. There's a particular gap between the 2 that should be adhered to. And so taking the second dose incorrectly increases complications for the woman, and she may require surgery, which again negates any so-called benefit of an at-home abortion. And just generally speaking, as many as half of recommended protocols for prescription drug use are not followed, or not followed correctly. Obviously, the other side talk a lot about trusting women, but, you know, as a woman myself, I don't think we're any more superior to men in these things. And if people generally often don't follow proper drug use, I don't think women are particularly specially endowed with it to do so. So that's one risk. Another is missing an ectopic pregnancy. So that's when a pregnancy develops in the fallopian tube, which can be life-threatening. It's a very dangerous condition. So if the consultation is only happening over the phone, there's no scan going on, there's no physical examination as would happen in a clinic, that can be missed. So that obviously in that case, the woman should not be taking abortion pills. She should be getting treatment for the ectopic pregnancy. In a report from the American Food and Drug Administration, 97 ectopic pregnancies were reported after women took mifepristone. So the initial consultation had missed the ectopic pregnancy. And then there's the emotional distress. Many studies show that women experience emotional distress after an abortion, and other studies show mental health problems for women after abortion. And home abortion may lead to more adverse psychological consequences. You know, as we've mentioned before, she may be alone, and she is going to be dealing with the remains herself. Some other risks that must be considered, the regulation. I mean, we've talked quite a bit now about how we don't know that, the abortion providers don't know what gestation a woman's at. And we know that there have been cases of people taking the pills after the 10-week limit, and even after the 24-week limit. Domestic abuse, again, we've gone through that quite a lot. That's one of the risks of that. And also missing the opportunity to detect domestic abuse. Right, yes, I'm being told we haven't got very much time left, so we'll just try and be... Anything you want to say on this one, Kevin?
Let me just summarize very quickly on this one. Okay, just comparing the in-clinic assessment with the telemedicine. So in-clinic consultations and assessments will overcome the gaps that we've noted, both in safety and safeguarding from the telemedicine only. So clinicians will be able to verify identity of the woman. They will be able to accurately, professionally assess the gestational age of the pregnancy. They can assess the clinical eligibility of the woman for medical abortion treatment. In the clinic, they'll have the opportunity to discuss things in private about any concerns she might have, any risks of coercion or abuse. And importantly, they'll be able to have certainty that it is this woman, the woman present in their clinic room, that is the one taking the prescribed abortion pills. Okay.
Okay, so the final few questions are what I would call equalities questions. So looking at kind of categories under equalities legislation. So question 8 is, to what extent do you consider making permanent use of both pills could have a differential impact on groups of people or communities? So the protected characteristics that we thought were relevant to this were pregnancy and religion or belief. So under pregnancy, again, we talked about domestic abuse. DIY abortions can increase domestic abuse for pregnant women. Pregnancy can be a trigger for domestic abuse, and existing abuse may get worse during pregnancy or after birth. And as we said, abusers who know that women can get abortion pills through the post will be able to cover up their abuse more easily. And high levels of abuse has obviously been recorded during the pandemic. Pregnant women who are abused are at a greater risk from abortion. In a study of London clinics, there was a 6 times higher rate of intimate partner violence in women undergoing abortion compared with women receiving antenatal care. And yes, so women seeking abortion are in a higher risk category for domestic abuse, and victims of the abuse are at risk of being forced into abortion. And as we've mentioned, home abortion removes both the opportunity of detecting abuse via a private consultation and makes it easier for abusers to force a woman into abortion. So that's the pregnancy characteristic. It's also possible that the religion or belief characteristic could be affected. So there might end up being problems about conscientious objection for hospital staff, perhaps who have not normally been involved in abortion care, such as having to post out the pills. So that's just one possible thing. And question 9 is also a kind of equalities one. To what extent do you consider that making permanent home use of both pills for EMA, early medical abortion, would increase or reduce the difference in access to abortion for women from more deprived backgrounds or between geographical areas with different levels of disadvantage? So this is talking about poverty and where people live. And an important point here is that poverty can actually drive women towards abortion. Statistics from the Department of Health and Social Care reveal that women living in more deprived areas are more likely to have abortions than women living in less deprived areas. The rate in the most deprived decile is 26.1 per 1,000 women, which is more than double the rate of the least deprived decile of 12 per 1,000 women. And the important point here is abortion is not a solution for poverty, and there's a risk that abortion pills by post will be promoted as being especially important for women in deprived areas. So you can say, you know, you're struggling with this, we can just post you an abortion pill, problem over. And obviously that does not mean problem over. And the ease and speed of getting these abortion pills will mean that women who are considering abortion for financial reasons will have less time to make their decision, and they might not get any help they need to deal with their circumstances. What would you like to say on this one?
I think the only thing to add, given time, is that we think safe provision really can only be done in the clinic, and if funding, if out-of-pocket expenses and for the woman getting to the clinic is an issue, then just to emphasise that perhaps the NHS should be helping to refund those costs, making sure that cost is not a barrier to the woman attending the clinic. Okay, nothing else.
Great. And then question 10. The last proper one, but also the most important. So this is asking what should happen to this provision. So should the temporary measure enabling home use of both pills for early medical abortion, should it become a permanent measure? Should it end immediately? Should it be limited for 2 years, as in the Coronavirus Act? Should it be extended for a certain amount of time? And obviously what we want you to say here is end immediately. If you get nothing else out of this, if you answer nothing else, this is the most important one. It should end immediately. This should never have happened. It came in with no parliamentary scrutiny, with no health considerations. Pandemic or no pandemic, women deserve better, and it should be ended immediately.
Absolutely agreed. No, absolutely agreed on this. And I think that, just that last point we'll finish on. Look, we were told that it was going to be just an emergency measure, that it was because clinics were shut and the risk of COVID infections and so on. But we see clinics are open again. They've been open for quite some time. Even during this lockdown, the clinics are open for business. And it's a very cynical approach for Hancock and his department, having told us that this was a temporary emergency measure to now be considering through this consultation making it permanent with no proper debate or discourse on the matter. So end immediately.
Perfect. And then there is another question about, have you any other comments you wish to make? And that's just a place to add in anything that you've not managed to fit into the other points. If you've got any of your own points, obviously, that we've not mentioned, that would be the place to put them. But yes, seeing as we're swiftly running out of time, should we hand over to Ben, who will lead us through some questions?
Hi, Alethea and Kevin. Thank you so much for that. Hugely helpful, even for myself. It was really great. And we'll just dive in with some questions that have come up in the comments during this time. I just want to clarify yourself. From Constantino Trippi, what are the effects, dangers of taking multiples of these tablets?
Yes, so obviously the second pill, the misoprostol, is the design of it is to make you bleed, so to bleed to pass the pregnancy. And even with taking the number that you're supposed to take, sometimes women do hemorrhage. We saw on that list of complications from BPAS, there's a certain risk of hemorrhage, and that's mostly what's happening to any of these women who are having complications. So taking more than you ought to would lead to a greater risk of hemorrhage. I think it's fair to say.
Great. Sarah Ward made the observation regarding question 3. What are regarding the risks and complications, particularly for a woman when she's on her own? That might be something we to consider. I know you kind of did mention that as well. Tracy Gregory asked, did Matt Hancock pass this bill? Kevin, you've been working very closely with us on this. Perhaps you could just explain a little bit more about what actually happened and some of the legal case that we've been through.
Well, I think that so Christian Concern has a lot of information up on its website on a page called DIY Abortions about its legal case, which has been through the court and is now hoping to go to the Supreme Court actually with it. But the issue here is basically there was no parliamentary debate. It's not essentially a change to the bill. Hancock, as the Secretary of State, has powers within the current Abortion Act to determine for him to decide where is the appropriate place for this to take for abortion to happen. And so he used those powers under the emergency bill for COVID to push this through without any real discussion. There are those better placed than me to talk about the legal aspects of this, but there is a legal case and it is pending for Supreme Court where they think Hancock overstepped his powers on this.
Yeah, it's probably worth mentioning in that first week of the lockdown that he was in Parliament saying that this was not the plan. And that it was kind of leaked through the Department of Health and Social Care. And after a backlash, he said, this is not going to happen. And as part of our legal case that we've been doing is seeking a judicial review, emails and evidence came up showing the access that pro-abortion campaigners, leading abortion activists have with some of the highest powers in government. And so it's been great to expose that. And we've been challenging that during the lockdown. Great. So, another question from Constantino: can someone order these pills over and over again?
Yes.
There's nothing stopping them doing so. Yeah, they don't. They're not requiring the women to take the NHS number, so they're not being identified. It's not being passed on to their GP. Yeah. Yeah.
There's absolutely nothing to stop you, and they don't do any checks on whether the addresses have been used before. We've gone public with 26 cases. We've completed a number of cases beyond that. But I don't have 26 volunteers. I have many less than 26 volunteers, and we've got 26 treatment packs. Yeah.
No, absolutely. Okay, yeah. And that really does tie in as well with some of the coercion, the abuse.
Coercion, exactly, yeah.
Definitely.
Another question: is mental health checked of the women at all? Presumably this could be either before or afterwards as well. Is there any?
There's no proactive check. I mean, there's a few questions asking, look, how do you feel about this? Are you able to cope? Do you have any issue? But they're very cursory. It's very, they just skim across the surface on the whole thing. We did test the availability of deeper counselling sessions, and in truth, they're not really being provided in a timely manner that would allow the abortion to occur even within the time limit. So, and follow-up counselling for some of these things is just not as easily available as some might need. That said, I do want to also just say on this, look, it doesn't matter, abortion providers are saying it doesn't matter what your reason is for having the abortion and choosing to have an abortion. You tell us why you're doing it, and what they do is they tick the mental health clause under ground C. So they turn it into, you can't cope emotionally with this. This is causing you emotional concern. And it doesn't matter what reason you give, 98% of the time it's turned around to, it looks like, dear, you can't cope with this emotionally, and that's what we're going to tick.
Okay. Great, that's helpful. Our friend and fellow pro-life advocate Claire McCulloch actually made the point regarding question 6, and you alluded to this, Kevin, regarding question 6, assuming the public's knowledge of the risks as though we're kind of medics and advisors on these kinds of things. And you did highlight how it is a cynical question. Would you advise that we highlight that, highlight the cynicism of the question, I mean, to me, the fact that question 6 is being asked shows why we should end it immediately. Would you advise on that?
I think if we just had to come down to one reason for rescinding this approval and going back to in-clinic consultation, it is the gestational age question. There's simply no way that you can assess correctly on telemedicine alone. That just isn't possible. And in asking that question, I think they are saying, well, this is an issue and we know it's an issue.
Great, thank you. So a question we've had is regarding the consultation, maybe this is a question for Alethea. Do the government, how constrained are the government by the government consultation? Do they have to follow the results of the consultation? Could you just advise on that, please?
Yes, after all this time saying that, yes, you must fill this in, actually, no, they don't have to follow the results. And we have had before consultations, they will consult and then do what they want to do anyway. But we have this opportunity to respond, where we have to raise our voices. And obviously, if we win the consultation, as it were, if we have far more people responding on our side, then it does help our case. But no, they're not legally constrained to follow the results of the consultation.
Yeah, and of course that can be a springboard for things that we can write to our MP about. The government are doing this thing.
One way for the campaigning. Consultation now, we'll be asking you to write to your MPs, anything that we can do.
Okay, great. And we've had a question comparing the risks of this with the risks regarding birth control and also the morning after pill. Are those risks completely separate? Should we not conflate that, or is there a possibility that they're quite similar?
Yeah, I'm happy to take this one. So people do get confused between the birth control pill, the morning after pill, and these abortion pills. They are different things. So the birth control pill it mostly works to stop ovulation, which would mean pregnancy wouldn't happen at all. It does also have a mechanism to stop an embryo implanting in the womb, which is why some pro-lifers and Christians will have an issue with it from that point of view. But it is different. So the abortion pills, they only work with a pregnancy which is established, the embryo is implanted. You're not going to take them until you know that you're pregnant. So I mean, you can take them fairly early, but you're not going to take them before like 6 or 7 weeks. So I think for these purposes, yes, they are different drugs doing different things, and we can worry about those at a different point.
Great, thank you. Thank you so much, Alethea. Thank you so much, Kevin. That's been really great and helpful, and I hope everyone has been finding it helpful. I'm just going to hand over now to Rachel McKenzie from Rachel's Vineyard. They do amazing work supporting women who've been through abortions and counselling them. So I'm just going to hand over to you. Thank you so much, Rachel.
Thank you very much, and thank you, Ben, for those questions. And Alethea and Kevin, I just want to thank you as well. I know filling the form for myself will be a lot easier now. I feel so much more confident. So yeah, I'm part of a ministry called Rachel's Vineyard, and it's a weekend retreat where we support those affected by abortion. And Ben rightly said that, you know, we support women, but I don't think many people realise and recognise that the trauma of abortion also means that we support the men, the grandparents, the siblings, friends who supported their friend to make the decision for abortion. So we support the wider community as well. And that also includes helping those that have been in the abortion industry. You don't even have to be Christian. I know personally, and from all the people, the many thousands of women I've spoken to over the years, that an abortion experience leaves people believing that there's no help out there, that no one will ever understand. And this is the biggest secret and the most unforgivable sin that they could have ever committed. And Rachel's Vineyard really supports them and makes them realise, you know, that there is hope at the end of the tunnel. And now the phone calls that I'm getting through DIY abortions, I'm now recognising that I'm now dealing with a new depths of a living hell that people are going through. Women have never felt so alone. They've never thought ever that they would ever come to this decision over a phone consultation. Women have said that they wanted to die along with the babies that they actually did see. You know, like Alethea said, you know, it's not a clump of cells. And these women at home are beginning to see this when they go, that was a baby. One woman that got in touch with me, who doesn't mind me sharing this, said that all she needed to know was, had her baby got a heartbeat? And she was well over 8 weeks pregnant at this time. And she knew that if she was told it had a heartbeat, then there was no way she could go through with this. So she said, you know, has it got a heart? Has my baby got a heart? And she was clearly told, no, it was just a clump of cells with a pump. She now realises that that was a lie, and she just is living in a horror right now. And she said that when she looks in the mirror, all she can see back is a dead face staring at her. I myself have had 2 abortions, and my children are not here today. Jude and Paul have no longer got a voice, and I have to be the voice for them and the voice for others. So please fill in this consultation. Please realise that you can save the future Pauls, the future Judes of this world. So God bless you and thank you.